Start now. So today, thanks Paige for recording. Today we're having Dr. Eric Green, and he does radiology at the College of Veterinary Medicine, OSU. And yeah, he's going to talk a little bit about that. And Dr. Green, if you want to share your slides, let me just make sure that you can. Okay, you should be able to now, so you can start whenever.
I can absolutely. Thank you, Sagari. It was really nice to be invited to talk to you guys. I appreciate the offer. Hopefully you'll find what I have to say interesting. It's a little bit about what I do every single day. So why don't we just get going? The first thing we're going to talk about is what is a veterinary radiologist? Well, that is a veterinarian who performs and interprets all imaging studies, and that could be radiographs, ultrasound, computed tomography or CT, nuclear medicine, magnetic resonance imaging or MRI on all species except people. So we're responsible for everything else. It's also known as diagnostic imaging because radiology really just doesn't encompass all of the imaging that we do, so it's often referred to as diagnostic imaging. So how do you become a veterinary radiologist? First, you have to be a veterinarian. So that's 4 years typically in a veterinary college. And then you need to have some real life experience. And that's typically in the form of an internship, which is usually a year or so, or private practice experience, just sort of practicing veterinary medicine and getting a good background. And then you have to apply for a residency in radiology. These are 3-year programs, typically at universities where you receive directed training specifically in all aspects of diagnostic imaging. And you may have noticed at the beginning of the talk that I had these initials after my name, ACVR. It stands for the American College of Veterinary Radiology. This is the body that oversees training programs and certification of veterinary radiologists. And they do this by, one, overseeing the program, setting guidelines for what residency programs must entail, those sorts of things. But then they also create and give the 2 examinations that you have to pass to become board certified. There is a written exam that is typically sat in the fall of the beginning of your 4th year. So after you've done 2 years of your residency, you can sit this exam. And provided that you pass it, then you can sit for the oral examination, which is typically a year later. So just after you've finished your program. The exams obviously will test your knowledge of veterinary imaging and your ability to interpret images, which is what we do on a day-to-day basis. And provided you pass both of those, you will become board certified by the American College of Veterinary Radiology, which then allows you to advertise yourself as a specialist in veterinary imaging. So then where do you get a job? So a lot of us work at academic universities like myself. There are at least 2 to 4 typically radiologists at most large veterinary colleges at universities. But then there is a very large private practice market as well. And there are very large referral hospitals that may employ 1 to 6 or 7 veterinary radiologists as well, depending upon how busy they are. And then, because our medium is digital, as you probably realize, you could actually be independent and be a teleradiologist, which means, like the veterinarian in the bottom corner here, you can sit around all day and read images that people send to you by the internet and provide assistance with those cases in that fashion. I do some teleradiology as well, in addition to being at OSU and teaching in the veterinary college. So why did I become a veterinary radiologist? Well, I was really interested in the subject as we went through the veterinary curriculum. I found it fascinating, but it's a great job. And I like to say that I basically do 3 things every day. I sit in the dark all day and I look at shadows and then I tell stories. And that's literally what I do. All of our images in some way, shape, or form are kind of shadows. And We look at those and we try to interpret what's going on, and then we tell a story about what we see, and hopefully that provides the clinicians that have asked for our assistance some help in figuring out what's going on with the animal that they're treating. Every image in every animal is different, so it's always fascinating whether it's a dog or a cat or a horse or pig or a llama, alpaca, doesn't matter. They're all really interesting and different, and so each one is unique, which is kind of fun because it's never the same game twice. I like to be part of the process of helping figure out what's going on with these animals that are sick. It's part of a puzzle. So we're really just digging down and trying to figure out, why is this animal vomiting? Why does this animal have a cough? What's wrong with this animal's liver? Those sorts of things. It's all part of a mystery, and I enjoy being a part of that to help others in the hospital work through their cases and help them get an answer. So let's sort of look into each of these different aspects of diagnostic imaging. As I mentioned before, this encompasses all facets of imaging in veterinary medicine that include radiography, ultrasound, CT, nuclear medicine, and magnetic resonance imaging. And we're going to look at those a little bit one at a time here. So you may know this, but radiography uses X-rays to create images. As we see here, we have the X-ray machine and our dog patient here, and two of our eager students in the curriculum helping to restrain the patient, wearing lead to protect them from the X-rays. And the light that you can see shining on the patient is basically where we are aiming to make an image. And radiography works, or the image is created, because there are differences in the density of the tissues that make up the patient. And those density differences help to create the different shades of gray you see on a radiographic image. Like this image of a cat abdomen. So this is a radiograph of a cat's abdomen. And what you can see is, probably all of you can recognize that these are bones. This is the spine of the patient. The little bit of the thoracic spine here and the lumbar spine. We've got some of the pelvis over here, and the coxofemoral joints, or the hips, are right here. And you can see down here, we've got the abdominal body wall as this band of gray here. That's the muscular wall of the abdomen. And inside we have all the abdominal organs. The liver is sitting here, just caudal to the diaphragm. We can see some lungs just peeking in the edge of the image here. The stomach sits here, and it's essentially empty, so we don't have much but a little bubble of gas in it here. You can see both of the kidneys sitting here, and a lot of small intestines that have a little bit of fluid in them, these gray segments here, and then a little bit of gas with the darker gray in them. And then, of course, we have the colon here, filled with some feces on its way out. And the urinary bladder would be this large round thing here. And all of this is possible because all of these organs have different densities to them and are made up of different atoms that make them more or less opaque to the X-rays. And some of those, like bones, or say this metal R marker here, actually stop the X-rays from penetrating, and you get white areas on the image. Where there's nothing, like the area around the patient, where there's just simply air, you get black on the image because all of the X-ray photons made it to expose the image itself. And then you have all the shades of gray in between. This image is beautiful as far as radiographs go because we can see everything perfectly. And that's because this cat is quite fat. All of this sort of medium gray here is fat that surrounds all these organs, separates them, and allows us to see them really nicely. The next thing that we use is ultrasound. And this is a machine, as you can see here. It's a really big computer, and it has probes on it. And those probes actually create sound waves that go into the patient and come back as they bounce off of structures in the patient. And the difference is in the speed of sound transmission between different organs actually helps to create the echoes that we see on an image. This is an image of one of my former residents Ultrasounding a dog's abdomen, we usually just put them on their back in a nice soft padded trough and shave their abdomen so that we can get good contact. Ultrasound doesn't really penetrate hair very well because the air trapped within it tends to scatter all of the ultrasound back. So we need to shave them and put a little gel on the abdomen to get good contact, and then we can make an image. Images like this, where we have an image of the liver here, which is this structure right here. This bright white line that you see is actually the reflection of the ultrasound off of the air-filled lungs on the other side of the diaphragm. And so we know that we're in the cranial abdomen because we can see that diaphragm interface. We have a little bit of stomach here peeking out behind the liver. Here's another image of the liver with the gallbladder in it. This dark structure here is filled with bile, and there's really nothing in the bile to help create echoes, and so it appears black on the image. Here we have a little bit of small intestine. You can see that it's sort of a tube shape, and you can see that the wall itself has a different appearance to the layers of the wall. So we can see the difference between the outer portion, which is the serosa, and the muscularis portion and the mucosa, all because they have differences in the way that they reflect the ultrasound. And this patient just happens to have a lot of fluid in its abdomen, which is all of this black that surrounds that intestinal segment. And here's a nice image of an empty cat stomach. It tends to look like a little wagon wheel with the folds or of the rugae in the stomach here. You can see them undulating back and forth, and you can actually see the different layers within the wall itself, alternating bands of bright and dark echoes. Really useful modality for looking inside of our patients in real time, which is a huge advantage. Then we can move on to computed tomography, or CT. And here's an image of a CT machine up top here. This is very similar to the one we have in the clinic. And below, this is actually an image of the one we have in the clinic. And in this case, we're actually imaging a horse's head. We can image anything that fits through the hole here. Obviously, the entire patient in this case will not, but we'll be able to image the horse's head as it advances through this opening. And CT is kind of like radiographs in that it uses X-rays to help create a cross-sectional image. So using the same principles of radiography, the X-rays will pass through the patient, and the differences in the density and the composition of the tissues, just like radiographs, will help create the difference in the appearance of the image itself and the shades of gray. This requires a lot of mathematics that the computer does for us to reconstruct the image, because what's happening inside the CT scan is there is an X-ray tube, and this X-ray tube will rotate around the patient and constantly emitting the beam of radiation. On the other side of the tube are some detectors that act just like an X-ray plate to actually help receive the X-ray photons that have been generated. And it looks for the differences in their energy and how many of them make it through the patient. And through some complicated mathematics, actually builds the image on the screen. And because the image is being made as the patient advances through this hole, basically continuously, we actually get a cross-sectional slice of the patient to look at, like in this image here. So here we have a patient, it happens to be a dog that's under general anesthesia for a CT scan of its head. Down in this corner, you can see the CT machine will make some radiographic images that it uses to sort of tell us where we are. We refer to these as scout images. And in these 4 slices here that are color-coded to reflect where they are in the patient by these lines, you actually get a cross-section of the patient as it is advanced through the hole in the machine. So the most rostral portion, which is this salmon-colored slice that corresponds to right about here in the patient. This is a canine tooth. This is the tip of the nose. This is the back of the head over here. You can see, we can actually identify the canine teeth right here. They're made of bone or mineral, so they appear very white on the CT image. We can see inside the nose here, we have a cross-section of the endotracheal tube that's right here, and a little bit of the mandible down here. And as we go further caudal in the patient, We can see more and more detail in the nasal cavity here, some other teeth, some more teeth in the mandible. This wad over here is the patient's tongue that you can actually see off to the side. As we keep going further back in this yellow slice, more and more details until we get further back in this red slice, we can actually see the patient's eyes and a little bit of the brain here and some of the frontal sinuses. So this is, again, a really useful tool for seeing into the patient. And it has the advantage of allowing us to make a cross-sectional slice, and that avoids the problems that we see with radiographs. With a radiograph, we're taking a three-dimensional object, our patient, and we're compressing it into a 2D image. And what we lose is the fact that there's depth to that image, and there is superimposition of everything that is in that 3D structure compressed into 2D. CT avoids that superimposition by allowing us to literally slice through the patient and actually look at a slice of the patient without superimposition of anything else in the way. Really, really advantageous. Now let's talk about nuclear medicine. This is a tool that involves the use of a radiopharmaceutical. So we will inject our patients with a pharmaceutical that often will have a radioactive atom attached to it. And that radioactive atom will undergo radioactive decay naturally. And what happens is that while that substance is in the patient, depending upon the pharmaceutical that that atom is tagged to, it may go everywhere in the body. It may localize to certain tissues depending upon the characteristics of the pharmaceutical. It may end up in bones because of its propensity or attraction to the minerals in the bone. All of that is useful for localizing the pharmaceutical, and then naturally the radioactive element undergoes decay and gives off radiation. And so what we're doing with nuclear medicine is we're actually creating an image that is made by receiving all of this radiation that is being emitted by the patient with the pharmaceutical in it. And that radiation is received by what we refer to as a gamma camera, which is this structure right here. We obviously have a horse positioned in front of this camera. So we're going to be making an image of its distal forelimbs as they are right in front of the camera. So they're constantly emitting radiation now because we've given them the radiopharmaceutical. And the radiation that comes out of it is actually received by this camera. And that is created, that information then is used to create the image we see. And this is sort of a more functional study in that the pharmaceutical that we use and where it goes helps us to tell a little bit about the physiology of the patient. For example, one of the most frequent uses we have is for a bone scan. So we're looking at this horse to see where there are areas of increased bone activity that may indicate disease. And the pharmaceutical that we use happens to localize to bone, and it will localize there more readily where there's more metabolic activity in the bone. And so those areas will light up, if you will, and we'll see them much more readily. The one problem with nuclear medicine is it doesn't give us a really pretty anatomic image at all. And so here are some selected images of a horse bone scan. And you really have to know the anatomy to know what you're looking at. On this image up here on the left, it's actually the horse's right stifle joint. So this is the distal femur, the patella is sitting here, and this is the proximal tibia. And you can see that the bones stand out more than the soft gray of the soft tissue. So this is all of the horse's thigh muscle here. But you can see the bones much better because the pharmaceutical tends to localize in bone. This is an image taken from behind where we can actually see both stifles from behind and the tail hanging down here. It's a little difficult unless you know what you're looking at. And then this is the left stifle. And nuclear medicine images are different in that when we hang them up and look at them, we actually look at them as though we were the camera looking at the patient. And so the direction that we see this horse going in this image indicates that this is the horse's right stifle. And this direction, which is opposite, indicates that this is the horse's left stifle. We can go further down the leg to the tarsi here, and you'll notice that there is a very, very dark area that indicates there's lots of radioactive accumulation here. So this horse has a lesion in its right tarsus, somewhere in the distal tarsus. You can see this is the calcaneus here. This is the distal tibia. This is the horse's opposite tarsus on the left side. You can see that we don't have that same activity. And if we look at this image that was made from behind the horse with the right leg on this side and the left leg on this side, you can see that area of increased activity very clearly as we saw it on this more lateral image. So this is a really useful modality to tell us where to look. One of the most frequent uses of a bone scan in a horse is to do one when the horse is lame, and maybe you can tell which leg it is, but it can be very challenging. But you know it's lame because it's not performing the way the owner likes, and we can see that it's got a lameness in a limb, something like that. But it's very difficult to actually identify what part of the limb. Maybe it's in the stifle, maybe it's in the tarsus. It might not be that obvious on your exam. This is a great screening tool to help evaluate the whole horse and look for these areas where there's more activity that generally signals disease. And then we can choose a different modality to go and look more closely at this horse's left or right tarsus. Maybe we go and now make some radiographs. Maybe we think that a CT would be more useful, but we can do something else beyond this to actually identify what's going on. This doesn't really tell us what's going on, but more so where it's going on. So then we can move, I think, lastly, to magnetic resonance imaging, or MRI. This is pretty sophisticated. This is an example of a machine, typical MRI. It looks a lot like a CT, but it's a little bit bigger in that this hole is actually deeper. And what happens is we put the patient inside this device, and this is an incredibly strong magnet. And what this magnet does is it actually lines up all the hydrogen atoms that are in the patient, makes them all spin and point in the same direction, because essentially they're all tiny magnets with a north and a south pole. So every hydrogen atom in your body is a tiny little bar magnet, and they're all pointed in different directions normally. But if we put you or our patient inside this really strong magnet, all of those hydrogen atoms will line up and point in the same direction. And then what we do is we actually excite those atoms using a radio frequency pulse. So we actually beam in some energy through radio frequency that is tuned to the energy of those hydrogen atoms, and it gets them excited and causes them to tip around in the patient. And then when we let off that radio frequency, those hydrogen atoms will tip back to their natural position. And when they tip back, they have to give up energy to do so. And they give up that radio frequency energy that we gave them. And we can listen with an antenna in the machine for that radio frequency to come back out of the patient. And through some fairly complicated mechanistics, we can actually figure out what signals came from where in the patient and how strong they are. And that is what is used to actually create the image in the patient. So it looks kind of like a CT, except that there's a little bit more detail. And so what we have on the top left here is an image of a dog brain, and it's in a sagittal view. So we've cut through the patient on midline, and the nose is out here, and the back of the head is here. And this is the cerebrum here, and the cerebellum here, and the brainstem here. And we can see lots of things, like there's a vessel that's running here, and we can see all of this white around it is the cerebrospinal fluid that surrounds all of these structures. And depending upon, again, the characteristics of the tissue, we will see those things displayed in different shades of gray. So brain happens to look like this sort of shade of gray, and the fluid in here tends to be white. Muscles here are a little bit darker shade of gray. So again, it's really useful for looking inside the patient and has an advantage over CT in that it's much better at discerning differences in the soft tissues of a structure. So this is an example of a dog stifle or knee here. This is the distal femur. This is the patella. This is the tibia. We can actually see the patellar ligament, which is this dark band here. And if you're familiar at all with knees, we can see the cruciate ligaments, and those are the ligaments that hold the femur and the tibia together, and we can actually see them with an MRI, much better than we can with any other imaging modality, because they have different characteristics to them, which makes them look like dark bands on an MR. We know there's also fluid inside the stifle joint, which appears white here, so we can see that, and it helps to make these ligaments stand out nicely. So again, a really useful tool for examining soft tissue structures much more readily. You'll notice that the cortices of the bones in this MR are black, which is sort of opposite of CT where they appear white. And because we're looking at two different features of the tissues to help create the image. With CT, we're using the physical density and the atoms that are in the tissues themselves and how well they attenuate or absorb the radiation to create the image or cast a shadow. With MR, we're looking at the tissue characteristics as far as its rigidity, and things that tend to be more rigid or firm tend to look dark on an MR image. So now I just have a whole bunch of fun images, and if you want to throw your answers in the chat, I've just selected some kind of neat imaging studies that you can look at that sort of shows you the spectrum of what we might do as a veterinary radiologist. So here we have a radiograph of an animal. Any thoughts as to what it is? I have my chat open so you can see. We've already got some takers. Yes, indeed, it's a bat. It's a flying fox. You can see it's actually a really large bat. What you don't know is really how big this is, but I can tell you that this L, which we use to mark the left side of the patient, is about this big. So you get a sense for how large this patient is. And you can see this bat's actually had a fracture in its humerus on the left side. It's got a little plate there with some screws in it that help to fix that fracture. You can see how long the radius and ulna are in this bat and how long some of the bones of their hands are. This is one of the distal phalanges here. So one of these tiny little bones is really, really long in the bat. You can faintly see some of the soft tissue that makes up the wing itself, but it's incredibly thin, so it doesn't really show up all that well. You can see the heart in the center here with all of the ribs around it and the lungs that surround that, and then everything in the abdomen here. And this bat also has had some intra-abdominal surgery because you can see tiny little metal clips that are probably used. My guess is this was probably some abdominal surgery that but somebody performed, and we use these clips to probably ligate some arteries in the abdomen. We've got a little bit of this is a cone mask, if you will, because this patient was under anesthesia and it was inhaling the anesthesia through a mask that you can see here. And here we have what looks to be some electronics, probably a pulse oximeter that is evaluating the heart rate and the blood oxygen saturation so that we can monitor the patient while it's under anesthesia. So kind of cool. We don't get to do that very often. Here's a good one. Anybody know what this is? It might look fairly familiar, but not too familiar. It's the chest or thorax of the patient, and it's a radiograph again. Got a guess for kangaroo, not a bad guess. This might help. This R again is about that big. So this chest is probably about like this big. Any other takers in this? It might look really familiar because it looks a lot like a human, but it's not human. Pig, interesting guess. You're close with monkey. It's actually a chimpanzee. So they actually look a lot like people. This is very similar to what a human chest looks like, with the heart in the center here. You can see all of the blood vessels that are going to the lungs, and the ribs, of course, and some collarbones up here, and the scapula with a little bit of the shoulder joint here, and proximal humeri. So kind of cool. All right, what do we have here? Probably get some good guesses on this one. This is another radiograph of essentially most of the body of this animal. Any thoughts on that? A baby flamingo, not a bad guess. Chicken is right. It's a chicken. You can see the comb here and the little beak here, and ever so faintly some of the feathers. Again, they don't show up very well because they're not very thick, and they consist of atoms that don't have high atomic number. You can see some of the tail feathers here, and the quills of them are a little bit more radiopaque. But again, we've got the skull here, the beak, we've got a trachea, which is this gas-filled tube here. You can see the cervical spine curves like that. Here's the wishbone, which is a modified collarbone. And the breastbone here, which is this keel right here. And this is the heart right there. And right behind the heart is the liver. And then behind the liver is the stomach, or in the case of a bird, the ventriculus, or gizzard, if you will. You can see this foamy appearance up here, this sort of honeycomb looking thing. Those are the lungs that are just under the spine. This is the thoracic spine here. Got the pelvis here, and you can get a sense for some gas-filled tubes. These are small intestines in the caudal portion of the coelom here. And of course, the humeri and the wings are being held down out of the image. And here we have a drumstick. So this would be the tibiotarsal bone that has the drumstick on it. All right. How about this one? Bet we get a good guess on this. This is the abdomen. Another radiographic image of the abdomen of this animal. Alligator is absolutely correct. You can see all of their scales. They're a little bit more opaque and they show up. But again, we've got a lumbar spine, and we've got a femur here, another leg here with the tibia and the fibula. And then here's a hind foot and the big thick tail that you can see. Here's a little bit of the front feet that you can see with the little claws. And unfortunately, they had to radiograph this patient because this is the stomach right here. And unfortunately, this alligator ate a screw. And because the screw is metal, it shows up nice and white. So really good test if we're looking to find out if an animal ate something that might be abnormal or metallic. You can see it quite easily here. So that lets them know that yes, indeed, he ate a screw, and they can tell where it is. At least in this case, it's in the stomach at this time. And they could go in and get it out if they wanted by scoping it or some other way, or it's small enough. My concern is that it has a fairly pointy end, and we probably don't want to leave it in there, or it could actually poke its way out of the GI tract. Here's another radiograph. Clue is it's from the zoo, of course. What on earth is this? Whatever it is, it's the left one of this animal. Oh my gosh, Nicole's right. It is an elephant's foot. Can you imagine? So here we have the distal toe bone and the middle toe bone and the proximal toe bone. You can see there are 3 toes here. Other ones are sort of around off the edge. Obviously, an elephant's foot is really large. It's hard to get the entire thing on the image all at once. But we can certainly make a radiograph of their feet to make sure that the bones of the feet look normal. These do. This is what they're supposed to look like. But if he had an infection or something like that, we could actually identify that and look for changes in the bones and perhaps even the soft tissues. Okay, another radiograph. We're still at the zoo. I've seen this guess already tonight. Yeah, it's a penguin. It's amazing what they look like, isn't it? So they've got really interesting shape to them. Their front flippers, of course, are forelimbs, and we've got a nice humerus here, a radius and ulna, and then we've got the wrist and the rest of the bones of the hand, which form the nice flipper. You can see the chest here with the ribs, and the heart is right in the middle with the liver below it. And the rest of the organs of the abdomen are a little difficult to see because they don't look much different from each other, and there's not a lot of fat in here. You can see large air sacs because, again, it's a bird, and so they tend to have large air sacs within their coelom. And the lungs would be in the same place up against the spine. We just don't see them very well in this image. Okay. All right, so now I've got some more clinical cases to show you. So as I mentioned, we use this obviously to look for diseases in these patients. And so in this patient, this is a dog that presented with some clinical signs that led us to believe that there was something wrong with his brain. And so we did an MRI image of this patient, and we actually injected a contrast material, which allows different structures to change the way they look on the image based on how much of that contrast material goes to those particular sites. So the contrast material that we use in MR is injected into a. It tends, however, to localize where there are sites of lots of blood supply, because it is in the blood. And so where there's a vigorous blood supply, we tend to see this contrast agent collect. And what it does is, on an MR, this contrast material actually changes the magnetic properties of the tissue and changes the signal that comes out of the tissue and makes it much more strong and bright and white. And so things that have contrast in them, like vessels here, end up becoming very white, or something like this large mass that is lighting up with contrast and allowing us to see it much more clearly. This mass happens to be right at the base of the brain. We've got the nose end of the dog here and the back of the head here with another image of the cerebellum. This MR image is tuned, if you will, to look at specific things. And so it doesn't quite look like the image that I showed initially, because that was tuned to look at different things. But this image is tuned to really look at things that enhance with contrast. And so we were able to identify this tumor right here that's actually in the dog's pituitary gland, which sits right here. And so this dog has a pituitary tumor, which now at least we know what's wrong with the dog, and we can offer some options for treatment. Here we have a dog's leg, and the history on this dog is that he broke it a while ago, and you can see that it doesn't line up quite right. It's healed, but it's not healed straight, and that's okay. And it has some holes in it, and maybe there's some mineral in the soft tissues around it. But what we were seeing clinically is this dog had a recurrent infection, and there was always some pus draining out of this dog's leg. And we wanted to know if it was related to the broken femur that it had had in the past. And so what we did in this case is a special study we call a fistulogram. A fistula is a hole in anything. In this case, it was a hole in the skin. And we injected a contrast material into that hole. And that contrast material happens to have iodine in it. And iodine is essentially a metal. And so on a radiograph, it shows up as white. And through that, we were able to see where this tract was originating from in this dog and why it had continual discharge or infection coming out of its leg. And so this is really helpful because now the surgeons know that there is a long tract in here that goes down to the bone, that touches the bone, actually incorporates this bony piece here that was in the soft tissues. And so when they go in to remove the infection, they know exactly where they need to go to help remove all of the diseased tissue. And once they do that, we can, with some antibiotics, hopefully we can actually clear up the residual infection, and this dog won't have the continual draining tract in his leg. We can also do some other special studies using contrast material in our large and small animal patients. This one happens to be called myelography. And this involves an injection into the area of the spine where the spinal cord is, again, with an agent, a contrast agent that has iodine in it so that it shows up nice and white. And what this allows us to see is where the spinal cord is. The spinal cord is soft tissue. And so when we make a radiograph, we don't actually see it because it's surrounded by the bone of the spine. But frequently we can have diseases that cause compression of that spinal cord, and we need to see what's happening with it. So sometimes we may choose to do a myelogram to actually outline the cord. And so this light gray area you see in the center is actually the spinal cord that's being outlined by the contrast material, which flows around it. Again, helpful to allow us to see something that we normally don't see on a radiograph. And it allows us to identify things like this spinal tumor here. So we've got a nice cord here outlined by the contrast material, except for right here, where we see this area that doesn't have contrast in it. It corresponds to sort of this blob here. And because of this, we know that there is a mass there that is displacing the contrast material around it. And because of where this is located, our primary differential is that it represents a tumor in this dog's spine. This dog up here ate something and was vomiting, and so we made a radiograph of it. And while it is really useful, what we see is that here in this segment of small intestine, you can get the sense that there's sort of this foamy appearance to the contents of this intestine. And the other thing that we look at when we see this is that the small intestines here are really jumbled. They're not very relaxed and gently curving like we expect them to. They're all sort of wadded up in a bunch. This pattern is very supportive of what we refer to as a linear foreign body obstruction. So there's something in the patient's small intestine that is obstructing, but it's linear in nature. And what it tends to do is it tends to bunch up the small intestine into sort of this wad-like appearance. We took the same patient and we did an ultrasound, and what we have right here is a section of the small intestine, but right down the middle, we can see this very bright echo that represents whatever this linear material is that's causing the obstruction. So we can confirm with this ultrasound that this patient indeed does have a linear foreign body obstruction. So we can take it to surgery and remove that foreign material. Oh, another quickie. This should be fairly easy. We've got obviously a turtle, and is it a girl or a boy turtle is the question. Yes, indeed. We've got 2 eggs in this turtle, we can see. Turtles are a little challenging to radiograph because there's obviously a lot of mineral in their shell that surrounds them, but we are often looking for eggs within them, and thankfully, most of the time they have a mineralized shell so we can see them. This right here, this very metal thing, is actually a microchip. So this was a part of a collection where they microchipped their animals to identify them. And so we can see that also very clearly. Do you ever radiograph them upside down, the turtle? Well, the reality is I don't know if this turtle is on its back or on its belly, probably on its belly, to be honest, because it's just easier. And the image itself would actually look the same, whether we looked from one side or the other, because it's a radiograph, we're compressing that 3D into a 2D image. So it would look the same either way. We do radiograph them from the side as well, and also from the front, so we can look at symmetry from that perspective as well, because they do have lungs that are up in the dorsal part of their coelomic cavity. And so if we were to look at them sort of from the side or head on, we can actually see those lungs separate from the rest of their abdomen. Here's a dog, and this is the thorax, or the chest of the dog. The head is over here and the abdomen's over here. And what we normally would expect to see in the center would be the heart. But unfortunately, instead, we see all of these gas-filled tubes that are where the heart should be. This happens to be a hernia where the small intestine is actually herniated through the diaphragm and is now within the pericardium surrounding the heart. And we can identify that very easily on this radiograph. Here we have a horse that unfortunately fractured its middle phalanx or pastern here. You can see all of the tiny fragments of bone that resulted from this fracture. This is the distal end of the third probably front limb. So oh, it actually says hind. So this is the metatarsal bone. This is the first phalanx. So we're talking about this bone here, and then it broke this bone right here. And then you can see obviously the distal phalanx here and the hoof, and it actually is wearing a shoe right now. And we fixed it. So they went to surgery and they put 2 plates and lots of screws in here and tried to put the pieces back together. And then they put a cast on the leg. And so you can see the cast has this odd appearance to it with a lot of bandage material around that. So hopefully the goal of this is to actually get this joint to fuse to provide stability. The horse isn't going to be able to do what it used to do, but this horse should be able to walk once this fuses and, you know, can use it as a pasture ornament to trim your lawn, et cetera, et cetera. But at least we fixed it and made the horse more comfortable. Here's another image of a horse's head. The nose is over here and the back of the head is here. You can see his teeth and all of the air in the sinuses and nasal passages. This is where the brain lives, inside the skull here. And this horse was probably having some difficulty eating or exhibiting some odd noises when it was breathing. And it happens to have an abscess right here. So we can see all of this abnormal collection of gas in the horse's pharynx, right next to the epiglottis, which sits here. This is the larynx and the trachea here. So again, really helpful because we identified the cause of the problem right away with a simple radiograph. Here's another dog with a brain tumor on an MR image. You can see it right here with this image tuned to show the contrast much better than this image here. I want to leave some time for questions, so I'm going to just quickly look. That was the last one. So one of the other cool things that we can do with CT is actually make 3-dimensional images. So this is a dog's skull, and we imaged it because it has a tumor arising from its maxilla. And so what we did to help the surgeons is provide this 3D rendering of the dog's skull, which shows the normal side here, and then the abnormal side with the tumor, which has a lot of bone in it. And the surgeons find this really useful because you can actually plan the surgery from this. We've actually also 3D printed these structures so the surgeon can actually practice removing this on the 3D model before they go in and remove it in the patient themselves. So that's what I have. I want to make sure that I have some time to answer any questions you guys might have about veterinary radiology and what a pretty cool, awesome career it is. So happy to take any questions from anybody. I'll stop sharing unless you want me, if someone wants to look at an image again, I can show it again. But anyone have any questions for me? If not, I know you're experiencing as much Zoom fatigue as I am. All of the classes I've been giving this semester are all on Zoom, so I feel your pain. Okay, where do some of your radiology colleagues work? Is that what you're asking, Amanda? If you're asking where some of my personal colleagues, pretty much all of us, we almost know every one of us in ACVR. There are probably maybe 400 of us boarded radiologists in the world. I know most of them by name and many of them by sight, but the majority of them work in private practices or do teleradiology, simply because that's where the need is right now. And there are just physically more of those places. As you know, there are probably only 32 veterinary colleges in the US. And so there's just a limited number of places in academia that you can work as a veterinary radiologist, but that is a market that needs to be filled because we're losing a lot of academic radiologists because they tended to be older and they're retiring. And so it'd be nice to get some new faculty members at these universities. How long does it take to become a radiologist? I can tell you my story. It was 4 years of undergrad, getting a basic zoology degree, and then 4 years of veterinary school, which is pretty much typical. And then I did a 1-year internship in small animal medicine and surgery at Georgia. And then I did a 3-year residency in radiology, took my exams and got boarded. So you can do the math as how long that took. I actually wanted to do another residency, so I am double boarded in radiation oncology as well. So after my radiology residency, I did another 2-year residency in radiation oncology, took that exam and became boarded so that I can actually treat patients with cancer using radiation. So that was a little bit longer journey than most, and I've been at OSU since 2002. So almost 20 years coming up. Which animals would you say you work with the most? Academically, in the veterinary college, it's probably 80% dogs and 15% cats, perhaps. And then the rest are large animal patients. Depends on the day, honestly. Some days we do a lot of horses. We did a pig CT today. We've imaged alpacas and camelids, but the majority of what we do is small animal just because that's the nature of it. But we do have a really robust large animal population and a great large animal hospital at the college as well. So we see a lot of those animals too. And let's see, are there any foreign objects that are invisible on a radiograph? That's a really good question, Sagari. Because a radiograph relies on the physical density and the anatomic makeup of the object, if the anatomic makeup of whatever it is that was consumed is similar to the organs in the abdomen, we may not see it at all. So cloth that becomes wet ends up looking just like soft tissue structures, which is pretty much everything in the abdomen. So it can be really challenging to identify foreign material if it's not mineral or metal. So, and that's often very difficult for us. So in those cases, we might choose to do ultrasound, which uses a different means to make the image and makes those things look different. Or we might do a CT, and then we can identify it much more readily because we don't have any superimposition. Do I have any radiation oncology case studies? I don't in this lecture, sorry, because it was mostly about being a veterinary radiologist. But if you wanted to talk on that sometime, feel free. I'd be happy to discuss that too, because it's pretty cool. How much of your work is radiation diagnostics and how much is radiation oncology? That's a good question, Victoria. My appointment at the college is 80% clinics. So I'm on clinics 80% of the time. The other 20% I get to do administrative stuff, teach, and take a break. And I split that responsibility equally between radiology and radiation oncology. So roughly 2 weeks out of every other month, I'm devoted to seeing radiation oncology patients. I have other colleagues that will see it. We split that service. And then the other times I'm on radiology, sharing that responsibility with the other 4 faculty members that we have. Is the field growing? Absolutely. The veterinary radiology field is booming. There's more business out there than we as radiologists can keep up with, particularly in the teleradiology field. And so we desperately need radiologists. And so radiology residencies are very competitive. We have a position every year that we fill for another resident, and we receive usually 80 to 90 applications every year for one position. So it is really challenging. There were 25 radiology residency positions open this year. So if you do the math, more than 2/3 to 3/4 of those people might not get a residency. So oftentimes we see the same people trying again. Usually after the second attempt, we usually see that they end up matching to a program, which is good. What's the hardest diagnosis to identify on a radiograph? Well, that's a really tough question. It really depends on the species and what's actually wrong. There are certainly lots of diseases that don't look, that we cannot identify on an imaging study because it just doesn't change the anatomy to the point that we can actually identify that. There are some things that are really difficult to make the diagnosis of on a radiograph, but are really easy with an ultrasound because of, again, the nature of the imaging and how it looks at different things. The same is true with CT. So, you know, if we have a high suspicion of a foreign body in a dog, but on a radiograph we can't see it, we'll probably consider doing an ultrasound or a CT to identify it, and then we'll be much more confident. Really good questions, guys. Thank you. And I know that it's 8 o'clock, so I do want to respect the time. So if there's anything else, happy to answer it. Otherwise, I really appreciate the opportunity to do this, and be willing to do this at another time for another subject if you wanted. No worries.
Thank you so much for coming.
I really appreciate it. It was a lot of fun. Hope you guys thought it was fun too and got something out of this. And maybe I will see some of you in an upcoming veterinary class. Wouldn't that be cool?
Thank you so much.
You're very welcome. Everybody, take care and have a good night, and good luck on